Hello everybody, welcome. Do not adjust your sets because I am definitely not Sophie Scott. Sophie sends her apologies. She has been tied up on a breaking story and she can't be with us just yet, but she's going to join us a little bit later. Now, I just will do this and this. Sorry, bear with me for 2 seconds. So, yes, so as I say, Sophie will be with us a bit later on. She, of course, is the national medical reporter at the ABC. I am her colleague. So I want to start off just by paying my respects for the traditional owners of the land, the Gadigal people of the Eora Nation, and acknowledge any Aboriginal Torres Strait people in the audience as well. Now, if you would like to post on Twitter or Instagram about this event, then the handle is at George Institute. You can also post on @SophieScott2 and the hashtag is George Talks. So thank you so much for everybody for joining us. This is a really interesting subject. We know everyone's time is valuable, so we're going to move through this as efficiently as possible. Most of us might have heard about what sepsis is, but what you probably don't know is that the sheer numbers of people affected by it are quite staggering, and of course the toll that it can take on people and their families is really devastating. Actually, my grandmother passed away some time ago now from sepsis, so I know a bit about it myself, but I was really shocked to know that in Australia 50,000 cases a year or 1,000 cases a week occur. The George Institute for Global has gathered one of the world's leading experts in this area, and we're lucky to have him here with us today, Professor Simon Finfer. He is a professional fellow in the Critical Care and Trauma Division at the George Institute for Global Health, and he's a champion for, well, he's a champion overall, but he's also a champion for sepsis survivors. He established the Australian Sepsis Network, amongst other things. And we will hear from two families today that have been directly affected and impacted by sepsis. The first person is Matthew Ames, who's 39 years old, was 39 years old when he started with what was essentially the innocuous sort of thing of just a sore throat. And that resulted in the very end of the whole process in the loss of all 4 of his limbs, which is a tragic story. He contracted streptococcal, resulting in toxic shock, and was never expected to survive. But now, 8 years later, he has beaten the odds. He was spurred on by the fact that he's the father of 4, and his husband, he's a husband to Diane. And between all of them, he found the strength to go on and grow old with them is what he wants to do, which is a great goal. Now, we're also going to hear from Mary Steele, and Mary lost her son to sepsis, very sad. 2.5-year-old Preston was apparently diagnosed with pneumonia, which caused an acute lung injury. A second bacterium then took hold, which led to the sepsis. Both Mary and Matthew and the professor are vocal advocates for raising awareness of sepsis with medical experts and the community, so that others do not suffer the sort of things that they have had to go through. So let's start with Mary. Mary, thanks for joining us.
Thank you, Phil.
Can you tell us a little bit about what happened with Preston and how long it took to find out what had actually happened to him, as distinct from what you thought had happened to him?
In all 2003, I lost Preston. He was 2.5 years old. A few weeks prior to his dying, he was diagnosed with pneumonia. Well, it sounds pretty severe for a 2-year-old to have pneumonia. Preston was a child that had sort of chronic and pneumonias. I think he had probably of it. And so when I first presented to the emergency room those couple of weeks before he passed away, I actually knew that he had pneumonia. His pneumonia was always every time he got one, it was kind of hard to hear. He wasn't a real wheezy kid or anything like that, but I could just tell by his behavior and what, you know, watching his throat and the things that I learned to was unwell. And he'd always bounced back, even though he seemed to be chronically ill. He's a big, robust kid, so the pediatrician was never very worried. They just said he's going to be one of those kids with respiratory problems, and he will grow out of it. And you know the signs, you know what to do. So I presented to the emergency room, and they had said to me, they didn't believe he had pneumonia because they couldn't hear it easily. But then I advocated for them to take an X-ray, and sure enough, he did. And they took a blood test, and they started treating him for a pneumococcal pneumonia. And over those couple of weeks, he just wasn't getting better. He was, not himself. A 2.5-year-old can't really tell you what's wrong, but you know they're just not themselves. So I went back to the emergency room, and in the couple weeks when he was starting to get really lethargic, I said, look, today he doesn't even want to eat, not hot chips, not any of his favorite food. He doesn't want to watch the Wiggles. I think there's something seriously wrong. In my heart, I felt there was something seriously wrong. And was the Modern Children's, and they actually opened up the respiratory clinic to have a good look at his stats and everything. And they did quite a thorough look, took another blood test, came back, and they said, you were going to treat him for a mycoplasma pneumonia, which was different than a pneumococcal. Go home and give it time to work. And of course, the day he was just getting worse, and I rang and I said, something's terrible. He's getting worse. The way he's breathing's not right. And they said, just give the antibiotics a chance to work. By about 6 o'clock, I could just hear that his lung, it just didn't sound right. And I picked him up, and he actually vomited blood all over me. It was critical. And we rushed to the emergency room. And at that stage, we're filling with blood what was going on. The head of the pediatric intensive care came down and said, we need to get him upstairs on life support and intravenous antibiotics. And the word sepsis still wasn't used at all. While he was on life support, and this is going into a couple hours, they had a diagnosis of sepsis, talking about complications with pneumonia. And they said, but they were preparing my for he's likely to limbs he might need. So they were preparing us for the gravity of the situation, but the word sepsis still wasn't used. Mm. He passed away after they did a couple of times, and then they just him the third time, and we were left with this belief that this child died of complications with pneumonia. Still, in his death certificate, it was complications with pneumonia and septic shock. Mm. But in that period post, the was incredible. Child had passed away and the bacteria that invaded his system was Pseudomonas, so a very common bacteria, so very rare for a child, normally healthy, to pass away. Sepsis caused by this particular bacteria, and he wasn't going to. He got together a group of doctors to kind of look at it, an infectious disease specialist, a geneticist, an immunologist himself, and they were trying to figure out what had happened to this child. And in the meantime, my friends and family wanted to do something to help the hospital. There were a few things that happened while he was dying. They didn't have the right support system for him, so they'd gone off to another hospital. They literally put a nurse in a cab and sent them to a different hospital to get a life support system. And I remember asking, will it save his life? And the specialist saying no, but it will make him more. And then sort of in this journey that my family and friends and I took was about, how children breathe and not press. It was just going to be one of those things. We were just an unlucky family, terrible tragedy. And then a few years following, the doctors whose research charity were starting to research more and more about Pseudomonas septicemia in children. And a couple of families had contacted me through my son's charity to ask me questions about how my son died, because their son died the same way. Mm. And these doctors that were on my son's charity's website were the same doctors that were asking them questions about studying their children. And so I ended up getting these parents together because the doctors, I wanted to support their work, but they needed to be able to study these other children's tissues. And it's very hard as a parent to kind of hand over, even allow an autopsy, nevertheless to hand over,
And I
more research to
appreciate you
some.
very much telling your story today, because I know how painful it is. I lost a son myself, and so we all
Sorry,
appreciate
Phil.
hearing that
Yeah.
story. So it's very hard, but it was some time.
So it was years later when these families
years
came
later.
together. Yeah, and then they started talking about researching sepsis. Sepsis was why my son died. And
Did that surprise you that it took so
yes, yeah.
long?
Um, Look, probably yes in hindsight. I think I found it very hard to take other people's easier to live thinking that it wasn't going to happen to a lot of other people. It was very rare.
Yeah.
I think the fact that it wasn't so rare, but at the time, Phil, I don't feel like anyone missed anything purposely or they didn't look deep enough. I just don't think they knew.
The system.
I think sepsis has come a long way as far as it's treatable. There's a short period of time. This should be our focus rather than the.
Right. And so you think things have improved somewhat?
Absolutely. Oh, amazing. The focus is, at the time, and it was still around the world, at being the source disease and not actually looking for early diagnosis and treatment of sepsis. They're still treating whatever the present allows the sepsis to take hold.
Right.
And I think that's actually what's shifting.
Right. Okay. Well, look, we'll come back to you, Mary. Matt, you started off with a sore throat, but like Mary's son, you ended up with sepsis. What were the red flags that you think the medical staff missed that could have alerted them that there was something else going on?
Yeah, I think for me, it started as a sore throat, but then a number of other symptoms arrived. I ended up with a fever, rigors or shaking. I ended up being photophobic, so I didn't really like light. I ended up with nausea. And then I also was dehydrated somewhat, and in the end, sort of a rash started to form on my arm. So, I presented a number of different times to a number of different scenarios. So, GP very initially, but then about a week or so later, ED on a Sunday afternoon, and then after that, another GP on Tuesday afternoon, and then another GP on Wednesday morning. So it was really, I really knew, similar to Mary, I knew something was wrong, and I reached out a number of different times. So,
what did you say when you reached out?
Usually when you kind of rock on up, you run through your symptoms and what's wrong, and I think probably the last one, my wife came with me, but she didn't think that anyone was listening to me. So, I think, telling the history, I'd been a very healthy individual. I'd never seen a hospital until this point. So I think it's really about understanding those and listening to those concerns that people might have.
And dealing with the medical profession at times can be very daunting for people who have not been exposed to it. Did you ask for antibiotics?
Yeah, I remember having a conversation about them, and the view was that I had a viral infection, then it wouldn't make any difference. In hindsight, it would have made a big difference for me.
Why? What made you ask for them?
Because because I'd had sort of a fever and flu-like symptoms. I think one of the things about sepsis is that crossover between viral and bacterial infection as well. And Simon's probably more qualified to talk about that than I am.
Yeah. But you had a feeling that was something that you should consider.
Well, also reaching out for, I wasn't getting better. I was continuing to deteriorate. What else can we do here? And looking for answers was really probably the key driver.
Right. Okay. And what do you want people to know in the general community? What would you like them to be aware of?
Yeah, I think for me, one thing that I hadn't really heard about sepsis. I didn't really understand or know the signs and what to look for and what to ask for. So I think in the community, I think it would be, we really need for people to understand what questions to ask, and and understand what the signs and symptoms of sepsis actually are. So they, in many cases, I meet many people who this happened to, and there are many cases it's been preventable. So, getting that word out there within the community, but also within the primary healthcare sector, recognising that sepsis is really very much an emergency situation, and directing people towards the ED and hospital wherever they need to, as soon, because time is critical in these situations. And
yes, it is.
You lose a lot of time at home if you're not going to the place that you need to be. And obviously with an ED, getting recognising that it's an emergency, picking it up quickly, and you're not sitting in the, waiting for a long period of time is critical as well.
Yeah. All right. Now, you're all very fortunate because we're going to now hear from the professor. But before we do, he's also going to be happy to know that Sophie Scott, the national medical reporter for the ABC, is now going to join us. So I'm going to bid you all adieu. Thank you very much. Thanks for sharing your stories, Mary and Matthew. That was great. And I'm sure that people find it interesting to see it from the patient's perspective. So good luck with it. I will leave you to it. I will take my dog, Sammy, with me, and we will depart.
Thank you, Phil.
Thank you, Phil. Thank you, Phil. Thank you very much. So yeah, apologies for not being available for those last few minutes. The downside of being a news reporter is that breaking news happens and you actually just have to drop everything and react. So I apologise for that, and thank you, Phil, for stepping in. So we've heard from Matthew, we've heard from Mary, and now Simon, we're going to hear from you in terms of sepsis. I'd just like you to take us through just some of the key stats. How common is sepsis in Australia?
Thanks, Sophie. I'll preface what I say by saying that, obviously what we've heard from Mary and Matthew are terrible stories that are unfortunately all too common. And I think one of the reasons for that is because sepsis is still a clinical diagnosis. There is no diagnostic test. You can't do an X-ray to see sepsis. You can't take a blood test that that may indicate sepsis is likely, but there's no definite diagnostic test for it, which has also meant that having accurate statistics has been challenging. And we've had good statistics about patients treated in ICUs because we have a national database of all those patients, and those statistics, and up until very recently, all our data was based around that. The Global Burden of Disease project, which runs out of Washington State, has recently done a global estimate, which includes data from Australia. And their figures, which I still think may be a bit of an underestimate, would be 55,000 cases in Australia each year, resulting in close to 9,000 deaths. So it is a very major problem.
But I might just interrupt there for a minute. So even though, Simon, you said that there's no specific test for it, are there some red flags, or are there some sort of clinical signs that both patients and doctors can be looking out for, which might suggest that it is sepsis? Yeah.
And again, I think Matt's story is very illustrative of that, because sepsis results from an infection. Sepsis is life-threatening organ dysfunction occurring as a result of an infection. It's not the infection itself, it's your body's immune system response to that infection. So there is a transition frequently from someone having an infection and as Matt described, having flu-like symptoms and going to an emergency department and being told, reassured and sent away, which may be very appropriate. But then what's needed is for the community and medical professional or healthcare providers to understand when that is transitioning from a controlled or treated infection into sepsis. And there are some clear signs, the things that happen when people start to be affected, their organs start to be affected, developing a...
And what are some of those signs? Just take us through. So it's things like the rapid heart rate and the rapid breathing. Can you take us through some of those?
So yes, the rapid breathing is something people would be aware of. People may not be aware they've got a rapid heart rate unless they actually feel their pulse, but rapid breathing, fevers, shivering. People often will say, I just feel awful. I feel like I'm going to die. I've never felt like this before. Muscle pains, skin rashes. It affects the kidneys quite early, so people may not be making or passing any urine, may realize, well, I haven't actually, gone to the bathroom for hours and hours and hours. And a very serious sign is when people start developing mental confusion or reduced levels of consciousness. And of course, these are the classic signs, and there are two groups of people who are particularly at risk of sepsis where they may not be even that obvious, and that's the very young children, particularly young infants, neonates, and very old people, where it can be very non-specific. So elderly people, confusion for no other apparent reason, and small babies who may just be the classic floppy baby who's not responding, not feeding, things like that.
And they're also obviously not able to talk about, to say how unwell they would be feeling at that point.
That's right. So it really, the two prongs to this that we want to see to improve things, to stop what happened to Matthew happening, and to help families like Mary's, is for there to be an increase in community awareness, so people are aware, okay, I've been to the hospital, I've been sent, or I've been to my GP, I've been told I've got the flu, I've gone home, but now things are not going right, things are getting worse, and when I go back I want them to take me seriously. So it's to get people to go to a healthcare provider early, represent to that person or to a hospital if things are getting worse, and also for the healthcare providers who are in the front line to be aware, very aware, that this can be, as Matthew said, a time critical medical emergency, not something that you can come back to in a few hours and see how it's going.
So I just wanted to remind the audience that at about 12:40, we're going to open it up to questions from the audience. So if you do have a question, please write in your question, and those will be moderated and gone through, and we'll try to get to as many questions from the audience as possible. So just sticking with you, Simon, for a little bit longer, if a doctor does suspect that it might be sepsis, what are the tests that they can do to make that diagnosis?
So as I said, it is a clinical diagnosis. It is dependent on having a high level of suspicion that there's an infection present. And whilst you would take blood to look for bacteria, you'd collect urine to look for evidence of infections, etc. Some of those results you won't get, like cultures, you may not get for a day or two.
And that's obviously going to be way too long. Like, you don't have that time. You don't have a day or two to wait. Yeah.
So there are recognized protocols for people with suspected sepsis, which is to gather those samples where appropriate as quickly as possible. And if someone is showing signs of organ dysfunction, to start treatment with an antibiotic targeted at where the infection is likely to be and what's known about the bacteria in the area where they're coming from, and start those antibiotics straight away. Now, of course, sepsis can occur from non-bacterial infections, and we're seeing that classically at the moment with this coronavirus pandemic, which is killing people through sepsis. And whilst antibiotics will not be effective against a virus, if someone has organ dysfunction, if someone's organs are failing, antibiotics should be treated, and once it's confirmed that there is not a bacterial cause, the antibiotics should be stopped. Because there is this apparent conflict between trying to avoid developing antimicrobial resistance by giving too many antibiotics and not treating people with sepsis. So it's important that people get antibiotics quickly, because that's the one thing that has been demonstrated to reduce death and disability. But also that if those antibiotics are not appropriate because it's a viral infection, then they are stopped as soon as that's confirmed.
So we'll go back to the antimicrobial resistance in a minute, but just you mentioned it, and it's a perfect segue, Simon, just to get you to talk to the audience briefly about this link with COVID-19. You know, people, when we've been talking about coronavirus and COVID-19, you hear that the patients that get very sick with it and the ones that often end up dying have this cytokine storm going on where their organs are failing. But you were telling me, and I think the audience would be fascinated to hear that what's actually going on is really sepsis is happening. So can you take the audience through that?
Yes, I mean we've heard a lot of terminology used, like for instance, you say cytokine storm. This is exactly what happens with sepsis from any cause. What's unique about what's happening around the world at the moment is that there are literally millions of people getting sepsis caused by the same identifiable microorganism, in this case, a coronavirus, for which we have no effective antimicrobial treatment. And we currently have no vaccine, which is obviously where you disappeared off to talk about.
And we thought we might have one until last night.
Well, we might still.
Exactly. That's what I just said on there.
There's a very famous physician called William Osler who said a lot of clever things, and more than 100 years ago said in most cases people do not seem to die of an infection, they die of their body's response to the infection, and that is sepsis. And that is what's happening with the coronavirus. And you hear this classic story of people being a little bit unwell for a few days and then suddenly deteriorating, and people are needing blood pressure support, people are needing dialysis for their failed kidneys, and these are the effects of sepsis.
And so just to be clear, because it was my understanding, which was incorrect, that sepsis is generally caused by bacteria or an infection, but you were saying that it can be caused by a virus, like it is with COVID, and also by fungus as well.
Yeah. It can be caused by any infection because it's your body's response to the infection that is causing the sepsis. So normally, the majority of sepsis that we see, certainly that ends up in intensive care units, is caused by bacterial infections. It's caused by pneumonias, it's caused by intra-abdominal infections, urinary infections, gallbladder, bowel, etc. At the moment, globally, the global burden of disease estimates there's 55, somewhere around about 55 or 50 million cases of sepsis a year in the world. So in the first 6 months of the coronavirus epidemic or pandemic, there were, I think, 17 million cases of diagnosed of COVID-19, which is slightly less than you would expect from, normal everyday non-COVID sepsis. And that had resulted in just under 600,000 confirmed deaths. Whereas in that 6 month period, in a normal year, we would see 25 million deaths from sepsis, and we would see 5.5 million deaths.
But the numbers of when it comes to sepsis are absolutely staggering, aren't they?
Yes. And that's why the World Health Organization has now recognized sepsis as a global health threat. The countries like Australia, that are high-income countries with an advanced healthcare system, still have a major health problem, less so than obviously places like sub-Saharan Africa, but it is still a major health problem for high-income countries with advanced healthcare system, which Australia has.
So we're going to open it up to the audience, soon, and then we'll bring in Mary and Matthew to answer some questions. But before we move on from you, Simon, I was just keen to ask you about the Australian Commission on Safety and Quality in Healthcare, looking at some national guidelines, because I think you mentioned that Queensland in particular have done pretty well in raising awareness and having better clinical pathways when it comes to sepsis, but that other states and territories were falling a little bit behind. What are you hoping that the Commission on Quality and Safety, by developing the clinical care pathway, just maybe explain to the audience what that means, and what are you hoping it'll mean in terms of improving standard of care for patients, so that they don't have to go through what Matthew and Mary's family have been through? So
the Australian Sepsis Network is working with the Australian Commission on a clinical care standard and on some other planks, such as an awareness program. The clinical care standard is a series of fairly high-level statements which basically says what should the community expect from a healthcare provider and from the healthcare system, and that will be a national standard. You mentioned Queensland. I mean, Matthew and Mary are both involved with the work in Queensland, and would be very well placed to comment on that. And New South Wales has certainly led the way, I think, with its sepsis skills program. So there are significant efforts being made, and significant advances have been made. But really, we believe that every Australian, wherever they are in the country, rural, remote, city, every state and territory, and disadvantaged groups like Aboriginal and Torres Strait Islanders and others who are socially disadvantaged, everyone has the right to receive the same good care, and that's what a national standard and national guidelines can do.
So I might just bring in first Matthew and then Mary, just to talk about these proposed national guidelines. So first of all, Matthew, what improvement have you seen so far in terms of the clinicians' understanding and the community's understanding and awareness of sepsis? And what are you hoping, how far have we come so far, but what are you also hoping will happen in the future?
It feels like we've come a long way, but there is so much more to go. So really the focus has been on arming up the emergency departments to be able to accept and treat people well once they arrive in hospital. So that's really where all the initial work has been done by the Clinical Excellence Queensland group up here in Queensland Health. So the difficulty is that it's only just the start. You need to make sure, as I said, that the community is aware, and there's been a bit of awareness work done up here in Queensland on that. But again, it would be great to see that nationally and more done. And you know, we need primary health. We also need inpatient work, and we also need post-hospital care work done. So, you know, there's been some great advances in ED, but still a lot of other areas to address.
And what about Mary? We might just bring you in, Mary, from your point of view. What have you seen in terms of improvements, but also what would you like to see happen to move to the next stage, so that there's much more awareness and better outcomes for people whose families are affected by this?
Yeah, I mean, I agree with Matthew. It's come a long way. There's a long way to go. When I told my story, sepsis wasn't even a term attributed to my son's death. And to have a focus on it as something that needs to be early diagnosed and treated is, you know, a very long way. But I think, as Matthew said, the focus has been on the emergency departments, at least in Queensland too. They're separating out the adult from the pediatric, because the approach needs to be different for both those groups as well, the different needs. I think education and awareness, and I think across the regions, while there's been a lot of incredible work done in Queensland, it's also been because there are certain hospitals and certain groups who are willing to address it. It's not equal across the state by any means. And I think by having a national program where you expect, or I don't know if it's mandated or expected to address certain aspects of treatment, would make it equitable across the entire country as well, which is what needs to happen, because regionally and in areas that are not as how to say affluent, but if you look at the story of a little boy who died in Cape York from sepsis, the mother carried him back and forth to hospital, and just wasn't even considered, and this young child died. So it just equity across the nation, nevertheless, across the state, a lot of work needs to be done still.
And I mean, I guess the good thing about the clinical care guidelines is that it's a clear expectation, not only for medical staff on what needs to happen, but also it's designed for patients and patients' families as well, so that they know what should be happening. It's a clear sort of spells out for patients as well what's the best standard of care that needs to happen when it comes to a condition. We've had a couple of questions. I might just stick with Matthew and Mary just for the moment. And a question from Lisa was that, first starting with Matthew, saying, in terms of where you feel you might have been let down, do you feel that it was the health system that failed? It was decision making? The woman who's written this question said both of her parents have had bouts of sepsis in the last 2 years. And I guess she's just keen to sort of pick apart whether it was resources in the hospital, the fact that things escalated so quickly, or was it, I mean, it may be that it was a combination of all those factors, but are there any sort of specific things that you would pinpoint to as, key factors that were things that failed you? And
yeah, I think there's like whenever any major catastrophe happens, there's always multiple things that seem to go wrong, and I think that's certainly applicable in my case. So sepsis can be very fast, but I think, as Simon pointed out, I think I had a infection, then it transitioned. I think probably the particular areas for me, looking in hindsight, I should have just gone to ED and stayed there. So continuing in the primary health sector was probably not something that I should have done, because it wasn't.
And was that because the GPs were not really aware, or the GPs that you were dealing with were not cognizant of the fact that sepsis could be an issue, and that the fact that you weren't getting better with the treatment was maybe a bit of a sign that there may be something else going on?
Yeah, so the deterioration and the history and the symptoms were all, in hindsight, which is always a wonderful thing, fairly clear that, I was already in that sort of stage. So if I'd known more information myself, I would have gone to ED. So, but, as you mentioned, people actually understanding all those things and directing me where I should have gone is really a critical area as well.
And I might just ask Mary, there's another question from one of our audience, and who Matthew's asking, and Mary, this really reflects on the point you just raised about the case in Cape York. Looking back on what happened, how much did you feel that not being listened to affected you in hindsight? And what would you say to empower other patients and their families regarding this? So we'll start with Mary.
I think I would have framed the questions differently. And I always say, no one meant for my son to die. And at the time, I think everyone were doing what they knew to do. What I think all parents need to be allowed to do is ask somebody to look deeper. The clinicians need to trust that the parent knows that something is seriously wrong. Knowing the signs of sepsis will certainly help, but it could also be confusing to a parent. I mean, if there had been a poster up that talked about sepsis, I would still have been focusing on pneumonia and why isn't he getting better and he's getting worse, and can somebody look deeper? And I think that parents need to be empowered to say, please look deeper. I need somebody to look deeper into this. It's not right. And I think if I was able to ask that, somebody would have. And if I was told also, come back if he's not getting better, no one ever said that. It was just wait for the antibiotics to work. And so there's a few things that you don't even have to necessarily know about sepsis, or the signs of sepsis and all those more the detail of it, but know that if your child is not getting better, because as we touched before, a child can't tell you, The signs aren't, you can't tell if they're, you know, kind of going in and out of, you know, normal
They can't
brain behavior.
in terms of that feeling that Simon described of feeling extremely unwell.
Yeah.
A child or an older person, a very older person,
They can't communicate that to you. You can look at their nappy and see if they passed urine, but even that is probably the only thing. There was no rapid breath. He didn't have spots on his skin. The first indication for us was his lung collapsed, aside from the fact that he was very lethargic and didn't want to eat and was just kind of groaning in pain. But, you know, that family in Cape York, somebody should have just looked deeper. If the parent keeps coming back, you know, and this is where the pathway helps the clinicians, because it gives them some guide when they're so busy with so many things and they're looking at sort of the source infection. You know, to have a pathway allows the clinicians to have a guide to look deeper. And I think that's been a great development as well.
So there's a question from the audience which sort of builds on this from Hitesh, and they're asking, and this is maybe for Simon, what are the recent, if any, advancements towards a specific diagnostic test for sepsis?
So this is a very complicated area where a lot of
That's why we brought you in, Simon, as the expert.
I'm a very simple person. I want things to be really straightforward, but they're not, unfortunately. I mean, there is a lot of good work going on, looking at a variety of different ways. And maybe if I tell you, I mean, first of all, I'll reveal a conflict of interest, because I do advise a biotech company in Silicon Valley, and the reason I advised them is because it was founded by an young Australian guy who had a liver transplant, and he got sepsis 17 times, and he kept going to emergency departments and saying, I'm getting sepsis, and he kept being turned away, and then he'd go back 24 hours later and they'd say, yeah, you've got sepsis, we'll admit you to hospital. So he figured, because he could feel it, it must be measurable. So he is one of a number, his company is one of a number of companies that are looking at continuous monitoring of things, wearing a wearable patch that sends a wireless signal to a mobile phone that monitors your heart rate, your saturations, your watch that measures your blood pressure. So there's no one specific test as yet, and it may be there never will be. There are people working on panels of blood tests looking at gene expression, which genes are turned on when you develop sepsis. That's a little more complex. That's going to be an in-hospital thing. This system for monitoring vital signs and then it goes into some artificial intelligence algorithm, and it says, okay, you are developing sepsis.
Wow.
You can either send the message to the doctor. Now, you can't have that, well, you could have that on everybody in the world wearing that, but I don't think that's very practical.
So in what sort of circumstance, what sort of patient would be appropriate to have that? Would it be someone who was on antibiotics where they were deteriorating, or they had a couple of courses of antibiotics? The
population initially that company is targeting is people who are having, you need a population of patients who are at very high risk of sepsis in a relatively short period of time. And that's people who are having high dose chemotherapy for cancers. And they have a risk of having sepsis of maybe 15-20% within a 6 to 8 week window. So they can wear the monitoring for 6 to 8 weeks. The other population, and I think Matthew touched on this, and I think this is where there's a great deal of ignorance, both not only in the community, but within the healthcare system, is the after effects of sepsis. So people who have had sepsis have a 1 in 3 chance of being readmitted to hospital within the next 3 months if they've been treated in intensive care for sepsis. And the majority...
And what are they being readmitted for?
Most commonly, a repeat bout of sepsis, and other things like, and kidney failure is the number 2, or kidney problems is the number 2, and underlying health problems that they may have had. So there is enormous ignorance within the community about that, within the medical community. So we have the Australian Sepsis Network basically gets the bulk of our messages that we get from people in the community are on 2 issues. They're like Mary or Matthew, I've had sepsis, or something dreadful happened to my child to me, and no one knew it was sepsis. How come this happens? The second one we get is from people who say, I've had sepsis and I'm not right. I can't think straight. I can't hold down my job. I can't look after my children properly. I keep going to doctors, and I've read about post-sepsis syndrome, and everyone says, never heard of it. I don't know what it is. I don't know what to do about it. So that's another population there. People at very high risk, and it's part of our work with the Australian Commission is that we want the healthcare standard to
reflect that as well, that it's not necessarily a one-off event. And
from pre-hospital right through the hospital system and into post-sepsis care, because currently there isn't any post-sepsis care.
So that's so fascinating. There was just a question that came in. We've got lots of questions coming in, which is fantastic. One question which was from a GP, I think, saying what could be done to help GPs so that they can better manage a patient. Say, for example, if a patient like presented with symptoms similar to Matthew, to manage a patient like that and to know whether they should be sending them to emergency department or managing them in primary care.
Is that a question?
Yes, so Simon, what would you say? Like, what advice? And this is obviously something that the clinical care pathway will look at.
I think
people who are watching now.
That's what we want with this, with a standard and a guideline, and to engage with general practitioners, ambulance care, because 80% of sepsis is community acquired. It arises in the community. Often people think this is a problem that happens in hospitals due to superbugs. Well, it's not. 80% is community acquired, and they're going to, it's either going to, the patient or their loved one and parent or whatever is going to present to either a GP or call an ambulance, or present to an emergency department. So those are the first points of contact. And it's really about looking for those signs of sepsis. And the other thing I'd like to see is again, I think Matthew and Mary have intimated, is if you send someone away from your GP surgery or away from your emergency department and say you've got the flu, you give them a piece of paper that says, but if these things are happening, come back. Because that doesn't happen at the moment. People, that it's been happening. I mean, I trained in medicine nearly 40 years ago. And even 40 years ago, if you had a bang on the head and you went to an emergency department, you were given a card that said, if you got persistent headache, vomiting, etc., please come back.
Come back,
and, because this is signs that something bad is happening or it's not getting better.
And so do you think we need to have that sort of language and framing when it comes to having sepsis on the agenda? So if you don't get better in a few days, or if you're not getting better on the antibiotics, that you need to come back, it could be something more serious.
Yeah. And as what Mary said about the pathways, they are really important. And the other thing that makes them important, and this might apply to a GP, GPs are not junior doctors. They're very experienced people who have an incredibly difficult job to do because they've got to find the needle in the haystack. I'm in intensive care, that someone's found the needle by the time the patient gets to me. Within the hospital system and other systems is to empower people. Okay, the pathway says when this happens, I need senior help. So not a doctor in training, or someone who doesn't feel powerful within the healthcare system sitting wondering whether they should do something, but having a pathway that says, when this happens, when you see these things, get senior help. And I think all the sepsis pathways that are operating, New South Wales, Queensland, etc., do that. They clearly say, get
senior help. Mary, when you and I were speaking and you were talking about what happened with Preston, it was only when someone very senior got involved who knew what was happening, and they were, and maybe just share with the audience, because I wasn't able to hear your story when you were talking to Phil, but just if you want to just share again the fact that it was having that senior person, once they were brought in, they were able to say exactly what they thought was happening.
Yeah, exactly. And I did share that with Phil. I said at the point where were presented back to the emergency. Preston's lung had collapsed. His lungs were filling with blood. There was no one in emergency that really knew what was happening. They sent down the head of the pediatric intensive care who was on at the moment, and he right away said, you know, this child needs to be on life support. This child needs antibiotics, and you know, we were whisked away. But absolutely no one knew. They knew it was critical. They just didn't know what to do at that stage.
So we've got another question from another Mary in the audience. What changes would Mary, Matt and Simon like our doctors and nurses to make, aside from using the pathways? Are there any other things that you would identify, any other changes that need to happen? So maybe we'll start with Simon first, and then Matthew, and then Mary.
Oh, that's a big question. I think one of the first things is obviously what we've heard from Mary and Matthew, which is listen to the patient. You know, again, you know, someone coming back again and again, you know, they shouldn't be viewed as a nuisance. It should be viewed as a red flag. And hopefully everyone is taught nowadays that listen to the parents as far as children go. We have to develop, I mean, there's no quick answer to that question, because this is a whole of society, whole of healthcare system issue. And I think the reason sepsis has kind of not been prominent up to now is because if you have breast cancer or bowel cancer or prostate cancer, there is a group of doctors specifically dedicated to that, treating that condition. Sepsis, if you come into hospital with pneumonia, you'll be admitted under a respiratory physician. If you come with a ruptured gallbladder, you'll be under a general surgeon. If you come as a child, you'll be under a pediatrician. So the whole of the healthcare system may be treating people with sepsis.
But then there's no one actually where sepsis is their primary responsibility.
So intensive care doctors and intensive care staff in general have taken this on as their sort of issue, if you like, but it's not just limited to this group. And the emergency department is the other major area in the hospital, but it really is a whole of healthcare system. I think developing that awareness pathways and then dealing with this huge issue of post-sepsis care, where there is just currently, even in Australia, a bit of a black hole at the moment.
We've had a couple of questions on the post-sepsis care. One question from Peter, which was talking about post-hospital care. And Peter's asking, are there any emerging technologies that can assist patients to reduce the readmission rates from sepsis? Is there anything, Simon or Matthew, that you know about?
I don't want to be the only person talking on this thing.
No, that's all right.
The problem is that we're in the infancy of researching this issue. The awareness of these problems is less than 10 years old. So in terms of defining what can we do the best way to stop post-sepsis problems is
to stop sepsis.
Stop it in the first place, which we can do through vaccination. We can prevent the severe sepsis in many cases by recognizing it early administration of appropriate antimicrobial agents. And I did see on the chat there was someone asking about viral and fungal sepsis. We have effective antifungal agents, so it's really just some of the viruses, but you know, vaccination is incredibly topical at the moment because of coronavirus and COVID-19, but there you can get vaccinated against pneumococcus, against meningococcus, against Haemophilus, against a lot of the major causes of sepsis. So at the moment we don't know the best system to deal with it, but that's an area of research. But prevention is always better than the cure.
So I've got a question for maybe Matthew and Mary might be able to address this. And we've talked about the pathways, but Jade is asking, are there any groups or strategies being worked on in terms of a national campaign to reach a greater audience to raise awareness? So apart from doing media stories, and I've seen that, you know, Matthew's been in the media quite a bit, how can people educate the community about sepsis? So Matthew and then Mary.
Sure. Yeah, I think well, importantly, there is a national action plan which has been put together through the Australian Sepsis Network and, you know, the various state groups that have come together to put that together, which is a really good start. And there's some funding, I understand, Simon, on that is about to be sort of put together around some public awareness. So there's going to be more in that space, which is again just a start, but it's very small. So, you know, I actually think it's not just about the, yes, you can get in media and all those sorts of pushes that you can do, because, you know, quite often 24 hours later somebody's onto the next story and your story's probably been forgotten. I think it's more also about embedding it in, you know, all the different parts of the system. How do we get into the education of, you know, doctors and nurses and healthcare professionals as they go through, you know, how do we actually provide it when, you know, maybe you have a newborn child, you know, and the information packs that are in those. You know, I think we need to look at all the different opportunities.
All the different opportunities along the track.
Yeah.
And Mary, what do you think in terms of, it's obviously something that you have working hard at as well, is to raise awareness. What do you think needs to be done to increase that community awareness about sepsis, so that more people know about it, as well as, you know, doctors and nurses and health professionals, but the community as well? It's on their radar.
Yeah, it is, because it can happen to anybody at any time, and I'm more on the pediatric side. There's just such a number of audiences, and Queensland Health has done a pretty good job, but again, those are through their networks, and it's quite limited in what they need to do. But looking at the, as Matthew has referred to, the National Action Plan, I think, you know, building a national campaign where you're targeting, you know, not just the GPs and clinicians, but, you know, going in and targeting, you know, daycare centers, and you know, doing blogs and webinars like this, targeting specific audiences, parents of young children, and also going into the, you know, disadvantaged groups and targeting them through their channels. Particularly sepsis impacts Aboriginal and Torres Strait Islander families, high amounts of sepsis and cases of sepsis. So it really has to be quite a comprehensive campaign. It's got to be quite targeted to those audiences, and the communication has to be very clear and through the right channels. And hopefully it's something we can build on through the Australian Sepsis Network, which has done, you know, a brilliant job to date. So that's what we could hope for.
Thank you, Mary. We're going to have to wrap up in a second. I just had one question that I really wanted to get to from the audience. She said, I'm a nurse manager and have the privilege of educating ED and ICU nurses about sepsis, and she's doing an event on Friday, which is great. And she's just asked if each of the panelists could give the nurses one take-home message about sepsis, what would it be? So we'll finish off with this. And I know we've talked about how this is multifactorial, but if there's a key take-home message, particularly for nurses who might be dealing with patients in that ED environment. So maybe we'll start with Simon, and then we'll move to Matthew, and then we'll finish with Mary.
It would be to realise that sepsis is a time-critical medical emergency that should be attended to immediately, and to steal the UK Sepsis Trust's message, you know, just ask, could it be sepsis?
Could it be sepsis? Exactly. That's a great one take-home message. So hopefully that's useful for Lee and Matthew. What would be your one take-home message that you would want not only this nursing group but our audience for this webinar to take with them?
Since Simon stole mine, you know, the could it be sepsis? You know, the inquiring mind, I think is really critical. But, you know, really listen closely to the people in front of you. You know, they understand what they're going through, and listen to them if they're concerned. You know, take that on as your concern as well. But yeah, definitely, could it be sepsis?
And Mary, just wrapping up finally, what would you like?
Look, the only thing I would add to that would, from a pediatric point of view or parent point of view, is ask the parent, is this different than any other illness? And then to yourself, could this be sepsis?
Yes, parents do know their kids well. So look, thank you so much everyone for taking part in this wonderful webinar, as well as our audience that's been watching along with us. It's being recorded and it's going to be sent out internationally. And so all the messages and the fabulous information that you've given today will be heard and listened to and hopefully acted on by a really broad audience. And I hope this is not the end of this really, really important conversation about sepsis, because I think it's something we, you know, the three experts that we've got today have devoted a lot of their time and effort on this issue. And I think it's something we definitely need to continue to focus on, and certainly not move on to the next story as quickly as 24 hours, because those numbers are staggering. And I'm certainly going to be looking at this a lot more and making sure that, that we do put the attention to sepsis, because it's something that sounds like it's desperately needed. So thank you everyone for taking part, and it's been a fascinating discussion. Matthew and Mary, it is so valuable to hear from the patient and the family perspective, and I really appreciate your time and ability to be able to tell your story. I can't tell you how valuable it is to hear that. And of course we wouldn't have had all that amazing information without Professor Simon Finfer as well. And he's definitely not only a leading Australian expert, a world expert on sepsis, and we're lucky to have had him for this hour. So thank you, Simon, as well. We will be there is going to be a recording of this. So if you want to get that, I'm sure that the George Institute can send that out to you. And again, thank you very much. Apologies for I wasn't here for the first 10 minutes, but it's been a fascinating discussion, and thank you so much for taking part.
Thanks, Sophie.
Goodbye, everybody.
Bye, everyone.
Thank you.